So I'll be dealing with the common posterior segment manifestation and the management. Actually, this was since we work in the referral center where there is a ART center is there. So we see lots of these HIV positive patients. But it is important since we are number 3 in the world with the number of HIV patients. It's important everybody should know because these are classic clinical pictures which if you see the fundus you will not miss these because they are not seen in the normal patients actually. So if you see a classic picture and your mental picture is made and you can treat the patient or refer the patient early so that so many things can be, vision could be salvaged because what is happening is there are now life-saving drugs available. These patients are living very long now. I have follow-up for 12 years now. But once the retina is involved, once the ocular tissue is involved, this damage permanently, and they are not able to see with these eyes actually. So everything comes down to the ocular guys because their lives are now getting saved. But once their retina is involved, once their optic disc is involved, we can't salvage anything. So there is a greater challenge for eye specialists now with the heart therapy there. So as there can be various manifestations, but the commonest one is still is a non-infectious retinopathy, that is HIV microangiopathy, like the cotton wool spots or the hemorrhages, which can vary from a few to many there. So other can be non-infectious retinitis. In India, we continue to see severe retinitis. We have not actually come up to the post-heart era level like in the seen in the West. Like they say that they have become half, but in the Dr. Biswas group has reported something like 24.8% in their group. In Chandigarh PGI, we see something like 20% of severe retinitis, and rest of the infections are something like 1 to 2%. So what happens in these patients is it is important that it's not working. I'm sorry. Again, the CD4 counts are very important in these patients because if you see some disease and know the CD4 counts, it will help you to clinch a diagnosis because most of the retinitis, they look similar. So it is important to know their CD4 count sometimes to know that what is the disease likely, and it is important for the screening also. Since you know a patient who has a CD4 count of 500, he may not require screening unless until he is symptomatic. If somebody is less than CD400, so it is even if he doesn't have symptoms, he need to come for the screening. So there are things available. The screening tools are there, and screening guidelines are also there. Like I've already said, microangiopathy is one of the commonest manifestations. You see these patients like cotton wool spots, and the angiopathy can be there in these patients. What is important here is, I wish to again say, to follow these cotton wool spots because this is a patient from my 1998, my thesis time actually. I carry these slides all the time because this patient right in front of my eyes, these cotton wool spots developed into CMV retinitis and the hemorrhagic variety because we were not offering any treatment to these patients at that time. The intravitreal ganciclovir was not available. We were treating them with the systemic therapy. So this patient worsened in front of eyes. So this is how you look for the resolution of the CMV retinitis, the cotton wool spots, not this thing actually. So this is a proof that CMV retinitis and the cotton wool spots can co-merge. Probably these cotton wool spots are nothing but the precursors of CMV retinitis. They are actually not actual cotton wool spots, but they are the viral nodes there, which will ultimately become retinitis only. So again, as I've already said, the CMV retinitis, we are seeing lots of CMV retinitis patients in our population. In the West, it has gone down, but we are yet to see that kind of a downfall. Again, the clinical presentation can be classical. You have a granular pattern where you don't see much of hemorrhages, and these lesions are mostly start from the periphery. No doubt it cannot appear in the macular area also, but you will see these yellowish, full thickness, necrotizing retinitis lesions. And this is the edematous variety, which is classically the Pisa paris will see lots of hemorrhages over it, and they can be much more devastating. And this is again the frosted branch angiitis can present like this, and this is the classic bush fire which we read in the books, like the retinitis lesion is moving further and further, causing devastation of atrophy there, and the lesion is moving towards the periphery, or the peripheral region can move towards the center. This is a classic CMV retinitis lesion which cannot be missed with any other entity actually. So treatment is nowadays the treatment is available along with the heart. What we do is we give them systemic therapy. Why? Because the other eye involvement can be prevented and the other organ can be prevented. So systemic therapy is must. Local therapy is must because there are local drugs available which will act very fast and take care of these patients. Of course, the ganciclovir and valganciclovir both are available. The good thing is with the valganciclovir you need not give these intravenous injections because the bioavailability is so good, and of course the affordability is an issue here. But the valganciclovir oral dose is good for maintenance and induction. And of course, in these patients there is a things called induction and then maintenance. Induction means earlier you have to treat them with the higher drugs and then you maintain these patients till the time you see a hike in the CD4 counts. Again, when you're treating them with the intravitreal injection, we have to give something like 2 injections per week till the time the disease stops in front of eyes, clears up, and after that you start your maintenance phase till the time the CD4 count is more than 100 there actually. So in the pre-heart era, there was nothing like stopping the CMV retinitis ever. But nowadays in the heart era, when the CD4 counts become more than 100, you can stop the anti-CMV therapy, systemic as well as intravitreal. And this is the importance of heart in these patients. So what heart does is, it reconstitutes the immune system. So basic therapy is heart, and then along with that, you are treating the opportunistic infections with the drugs there actually. So we follow these guidelines. In these guidelines, you will see the word called ganciclovir implant. This is not available in India. Costs something like 3 lakh in Indian rupees, and it remains, their effect remains in the eye for around 3 to 6 months. That is why we give intravitreal ganciclovir, and it is being used all over the world. Since the half-life of ganciclovir is very low, that is why we have to give twice a week in these eyes actually. So this is what we follow in these patients. Of course, as I already said, the most common complications why these patients lose vision is either their macula gets involved or the disc gets involved, and the third is they develop retinal detachment because the atrophic areas, when they heal, they can develop the retinal detachment. I've already showed you these patients' atrophic areas, and this patient has an atrophic area, and this looks like anything can happen here, and this is what has happened here. So a large break has happened in the same area, and this is what is very common in these patients, something like more than 33%. And if you treat these patients with standard pars-mineral vitrectomy, there is with oil tamponade, with a gas tamponade, they generally do well in these patients. This is one such patient with a devastating kind of a retinitis all over. All we could salvage is this island of vision. So this is again in a patient 20, 200, 3/60 is good enough vision because this is oil-filled eye, and this is what we could salvage in this patient. Again, the next is the much uncommon are these acute retinal necrosis and the progressive outer retinal necrosis. These infections are also there we see in these HIV patients, but not that common. But what difference is there is in the while we are treating a patient who is immunocompetent with herpetic retinitis, is only difference is we are not giving steroids now. In these patients, the oral steroids, otherwise herpetic infection in immunocompetent patients, the antivirals are given with the steroids. But here the immune system is already compromised. We need not give steroids to these patients. They are just treated with the IV antiviral therapy followed by the oral and then with the aspirin drugs. This is the classic tongue-shaped lesions from the periphery you see in the ARN patient, and their behavior is almost same. In an immunocompetent patient also there is a risk of detachment is very high, and you treat these patients and they sometimes they develop these kind of detachments there. Again, the issue is, I said, the immunocompetent and immunocompromised, the lesions are same, but no steroids in HIV patients. Similarly, the progressive outer retinal necrosis patient, and how to differentiate between the progressive and the ARN is there is no involvement of vessels there. Overlying vessels you see are normal. Had there been the involvement of vessels there, we would have called acute retinal necrosis. Outer means the outer retina is involved beyond the retinal vessels there. Again, I've already said the treatment is same. You give intravenous ganciclovir, or intravitreal, but you need not give steroids in these patients. Actually, this is one such patient of a lady, bilateral pawn there. Actually, so she due to the massive this kind of a involvement, the risk of RD is also more. This is clearly shown that if the CD4 count is low, if the area of involvement of the retinitis is more, the chances of RD are more. So she developed this bilateral RD. These are silicone-filled eyes, and this much of, again, the island we could save. And she is something like counter finger 2 meter and 660 in these eyes. And these patients, even if they present early, nothing can be done, and you need to treat them with this kind of a surgery there. Again, the non-viral infections, the common one is a PCP, but we don't see in our part of the world here. So I'll not be discussing. The more common are what we see here are toxo there, and there is a resurgence of syphilis in the West. It's coming up in India also, and resurgence of TB also due to HIV in these patients. And toxoplasmosis, as I've already said, the classic toxoplasmosis is unifocal, unilateral retinitis, but again, it's a bilateral kind of retinitis, extensive one, and treatment is almost same in these patients. We treat them now with intravitreal Clinda or with the Septron there, along with the heart therapy. Again, this patient, you see that she had these classic old lesions, and she had these multifocal lesions, and the other eye was also involved. So classically, this is what we see in a patient of HIV. And to treatment, they do well, but if the macula is involved, nothing can be done, but much can be done in these patients. Tuberculosis, I've already said, talked about the resurgence, and they can be, lots of lesions can be seen in these patients, and the choroidal tubercles will be much bigger in size. You will be seeing the abscesses there, but they are treated same way as we treat the normal ocular tuberculosis. What is different here is, apart from the MTB, we see this atypical microbacterial infections with avium. This is one such Dr. Disha's patient who developed this avium, and from the PCR only, when we did vitrectomy for this eye, we could detect a mycobacterium avium. So non-tubercular mycobacteria are very common in HIV patients only. Again, the resurgence of syphilis, and because there is no difference, they present the same way. But of course, if you have a patient of HIV and you have a lesion, this patient presents with a papillitis there, with a vitritis there, and few retinitis patient, and it turned out to be a HIV positive. The treatment is same in these patients. We treat them with the benzyl penicillin, and they do very well in these eyes actually. These are the new things we see in HIV patients, like Dr. Amit said, the polymicrobial. So the systemic mixed infections are known in these patients. Similarly, we are seeing mixed infections in the eye. So if you see mixed infections in the eye, think of HIVs. We do see this thing. Like I've already shown this patient, this girl had PCR positive for toxo and VZV both. So she was treated with both the Septron and the acyclovir, and she did well, and we could salvage the 20/60 vision in the left eye. Similarly, this girl, if you see classically, you were seeing this occluded vessels there, and because of that, we thought of a frosted branch meningitis there. She must have had the healed lesion eye, and because of CMV retinitis, other eye had this kind of a large lesion, and this lesion regressed in front of our eyes. But when we did a PCR, we commonly don't do these PCR for these eyes, but for the academic purposes, whenever we inject, we take fluid to assess that what is happening. But it is not necessary to take confirm on the labs that CMV is there, because it's a classical presentation. But this patient turned out to be CMV and HSV both. So she was treated with IV acyclovir along with the intravitreal ganciclovir, and she did well, but we could salvage the vision in the left eye actually. Again, the immune recovery uveitis, this is nothing but, because, as I've already said, we don't see much vitritis in these eyes. We don't see immune-related problems, like we don't see CME in these eyes, and we don't see AC cells, we don't see, but once their CD4 counts build up, they start showing these things. So this is indirectly a good sign, but patient feels it's a bad sign actually, because patient gains vision, then he starts losing. Then you have to tell the patient, okay, you just wait for some time, things will be taken care of, because there can be development of macular edema, epiretinal membrane, and sometimes requiring even surgery. But they respond very well to steroids. This is the only indication in HIV where you sometimes have to give oral steroids also in case of a patient who had very severe vitritis in the form of hypopyon there. The immune recovery uveitis is so actually much that we have to give oral steroid in this patient. The CME is there. So this is the indication, only indication where you give low dose kind of a 0.75 mg per kg body weight under your own care for a few weeks, so that IRU is taken care of. To conclude my talk, in our settings, as I've already said, if you have asymptomatic patient, like screening is the best thing actually. Even if they are not symptomatic, you should be telling your ART centers or telling the friends who are dealing with these HIV patients that they should get the regular screening in these patients, must in less than 50. But in case they have floaters then, or any symptoms, they should come to you, SOS. But dilated fundus examination with indirect ophthalmoscopy is a standard for these patients actually. Thank you so much.